Hello class, this is Dr. Anderson again. So last time we talked, I was sharing some basics of endocrinology with you, and now we want to go through basic pathophysiology in the endocrine system. So there are a number of ways that things can go wrong. So for example, there can be a problem with the hormone level, too much hormone or not enough. So if there's not enough hormone, maybe it's because the hormone is being inactivated before it can reach its target, or it's being made but it's not able to be delivered to its target, or there's some problem in the breakdown pathway where the hormone is being broken down before it can reach its target. Or on the flip side, perhaps you have too much hormone because you have a tumor or some kind of ectopic source that's producing too much hormone. So that's one part of the equation. What's the level of the hormone? The other aspect of the equation is how is the body responding to the hormone? Is there some kind of substance, say an antibody, that is mimicking the endogenous hormone? Maybe there's something wrong with the receptor and now the hormone is unable to cause the appropriate physiologic response. Perhaps you have hormone, it's binding to the receptor, but the receptor is not activating the intracellular mechanisms that allow the physiologic response to take place. And finally, perhaps you have hormone, but when it gets to its target, nothing's there. Perhaps there's an immune problem where a gland is being attacked and there's nothing there for the hormone to activate. So we're going to see lots of examples of these ways that hormone signaling can go wrong. So we're going to start with the pituitary. You can have a condition called hypopituitarism. So the anterior pituitary is located within the sella turcica, and it only has a finite space. And perhaps there is a problem with the pituitary itself. That would be a primary problem. So perhaps there's a tumor, and that tumor is growing and compressing healthy cells. And now those healthy cells are unable to produce their secretory product, and that manifests as hypopituitarism. If it's a secondary problem, it's not that there's a problem in the pituitary per se, it's that there's a problem in the hypothalamus, and the releasing hormones are not making it, releasing hormones from the hypothalamus are not making it to the pituitary, and then the pituitary is not being stimulated. The pituitary is a very vascular gland, so it's very sensitive to vascular problems. If there's some kind of infarction or that kind of thing, that can damage the gland. So the pituitary produces a bunch of stuff. It has cells that produce thyroid stimulating hormone. Those are called the thyrotrophs. There are cells that produce LH and FSH. Those are the gonadotropes. There are cells that produce prolactin. Those are the lactotrophs. They're the cells that produce growth hormone, and I can't remember what those guys are called. And the cells that produce adrenocorticotropic hormone. So the symptomology depends on what hormones are being compromised. Okay, so hyperpituitarism. Typically, what's going on is there's a cancerous tumor called an adenoma, and it's in the pituitary. Again, it depends on which cells are affected as to what your symptoms are. However, again, let's say you have a tumor, you have an adenoma, it's growing, it's going to compress healthy cells. So you could have some cells that are overgrowing and hypersecreting, and then you have other cells that are being compromised and basically squished, and then they hyposecrete. Now, the pituitary is near the optic chiasma. So it is not unusual for pituitary tumors to grow, to push on the optic chiasma, and for there to be visual disturbances. There also can be headaches because of the tumor pushing on other structures. So the most common issue that comes up with either loss of pituitary function or excess pituitary function having to do with growth hormone. So let's review the effects of growth hormone. Growth hormone is a peptide hormone that causes growth. So that's its big function. Growth hormone binds to cells in bone, in muscle, in liver, and those cells then secrete a hormone called insulin-like growth hormone or growth factor, IGF-1. IGF-1 is a mitogen, which means when it binds to its receptor, it tells cells to divide. Growth hormone, one of the major metabolic actions that it has, is protein synthesis, predominantly in muscle. So we have an increased laying down of skeletal muscle proteins and that sort of thing. Other thing about growth hormone is that it has anti-insulin effects. So growth hormone is not going to have a direct effect, but helps adipocytes respond to stimuli that are going to tell those cells to break down triglyceride. It's going to promote gluconeogenesis in the liver to raise the blood glucose level, and it has a weird interaction with insulin. Growth hormone actually increases insulin, so insulin levels actually go up, but insulin is less effective in terms of stimulating glucose uptake by cells. So growth hormone tends to raise blood glucose level. So excesses in growth hormone cause what is called a diabetogenic effect. You'll have hyperglycemia and less responsiveness to insulin. This is a picture from a textbook called Tortura, showing us, here we have the hypothalamus. And the hypothalamus is going to produce a couple of hormones, growth hormone releasing hormone and growth hormone inhibiting hormone. And remember, I showed you a picture from Copstead where growth hormone inhibiting hormone was called somatostatin. It's the same protein. Now, it turns out a major stimulus for growth hormone release is low blood sugar. So hypoglycemia causes the increase in GnR, growth hormone releasing hormone, which is going to go down to the anterior pituitary. Anterior pituitary is then going to secrete human growth hormone. Human growth hormone is going to have all kinds of metabolic effects, elevating blood glucose level, promoting protein synthesis. We're also going to stimulate insulin-like growth factor. growth factor is going to cause cell growth through cell division. So the result is an increase in blood glucose level and an increase in growth. If blood glucose level continues to go up, then that high blood glucose level is going to inhibit growth hormone releasing hormone and stimulate growth hormone inhibiting hormone. Growth hormone inhibiting hormone would then inhibit human growth hormone and inhibit the production of IGF from the liver. There are lots of things that stimulate growth hormone release. Short-term stress, there's a circadian rhythm. We tend to release more growth hormone at night. So the regulation of growth hormone is actually quite complicated. This is the picture from Vander. So here you see a number of stimuli: exercise, stress. This is acute short-term stress, fasting, low plasma glucose, and sleep. This results in growth hormone releasing hormone, and notice here somatostatin. That's the same thing as growth hormone inhibiting hormone. If you increase GHRH, that goes in the portal system to the anterior pituitary, we get growth hormone secretion. Growth hormone goes to the liver, the bone, the muscle, all sorts of tissues. We get IGF-1. IGF-1 is going to increase cell division. And when IGF-1 is at high enough levels, it's going to feed back and inhibit the anterior pituitary and inhibit the hypothalamus. So, there is a condition where a pituitary adenoma in the anterior pituitary causes excess growth hormone and hyperpituitarism. If we are talking about an adult, we're talking about a condition called acromegaly. If we are talking about before puberty, that condition is then called giantism or gigantism. So there will be elevated levels of growth hormone, elevated levels of IGF. IGF will cause all, insulin-like growth factor, will cause all sorts of overproliferation. Lots of proliferation of the extracellular matrix. That makes these folks a difficult airway because of all the soft tissue growth in the pharynx. A very thick skin and difficult penetration with the needle. The bones thicken. There's a lot of thickening in the cartilage, and that causes a lot of joint pain. These folks produce more insulin, but they're less sensitive to it, and they're less able to take glucose up into cells, and therefore the growth hormone is considered to be diabetogenic. People who have excess growth hormone will have hypertension and heart failure attributed to these diabetic symptoms. Okay, let's talk about the thyroid gland. So here you see the thyroid gland in the sort of the base of the larynx. So there's the sort of the borders of the thyroid gland. Notice a very vascular gland and two lobes on either side underneath the larynx. Thyroid hormone, T3 and T4, are lipid-soluble hormones. They are dimers of tyrosine, one with 3 iodide groups and the other with 4 iodide groups. I will show you a picture of that in a second. So these are lipid-soluble hormones, and even though they're not steroids, they act like the steroids, so they increase gene transcription. They tend to increase transcription of energy-intensive proteins, enzymes in the Krebs cycle, enzymes in the glycolytic pathway, sodium-potassium ATPases. So you make more ATP and you burn more ATP. Thyroid function is essential in the fetus and in the newborn. It's essential for developing neurons, developing synapses, myelinating neurons, and babies that are born without thyroid hormone can be given thyroid hormone, and the deleterious effects can be avoided. If you have a baby that's not getting the appropriate care and not getting diagnosed, and they're hypothyroid, they won't grow the way they need to, their nervous system won't develop, and these children will be mentally retarded. Say 2 years, they're 2 years old and you discover the problem. They can be given thyroid or synthroid, and that will help some of the physical growth and the reproductive growth, but the brain development just cannot be gotten back. So all the kinds of proteins that thyroid hormone increases the transcription and synthesis of, that results in an increase in metabolism. If you're making more ATP and burning up more ATP, that is going to elevate the metabolism, and that's going to increase heat production. That's going to increase the oxygen uptake. Thyroid hormone upregulates beta cells, so there are all sorts of permissive effects of beta receptors. So there's going to be all sorts of permissive effects of thyroid hormone for catecholamines. So I showed you an example of increased lipolysis in the presence of thyroid hormone. If there are basal levels of epinephrine and you increase thyroid hormone, then the heart rate is going to go up. Contractility is going to go up. There's some permissive effects in the GI tract, so tending to enhance GI function, and because of the upregulation of beta receptors, there's an effect on the central nervous system. Central nervous system development, maintenance, and functioning. So the thyroid gland is organized into follicles. So here we see a capillary, and there's a little red blood cell. Here's a thyroid follicle. So there are cells on the outside of the thyroid gland, and then inside, let's see if I can get my pointer back. Whoops, here. Inside here is a colloid. It's called thyroglobulin. So notice, here's our cell. I think I'm going to go back and get my laser pointer. So here's our cell. Here's the basolateral side of the cell. We have a sodium iodide secondary active transporter that allows iodide to come in to the cell for the synthesis of thyroid hormone. Now notice, this is a tyrosine with 2 iodides on it. This is a tyrosine with 1 iodide. You put 2 tyrosines together. The dimer is the basis of thyroid hormone. If you have 3 iodide groups, you have T3. If you have 4 iodide groups, you have T4. T4, because it has 4 iodide groups, it is more lipid soluble. Its half-life is close to a week, whereas the half-life for T3 is about 24 hours. So we have these cells here that are, in response to thyroid stimulating hormone, are making thyroid hormone in a gigantic molecule called thyroglobulin, which is stored out in the colloid. In addition, with stimulation by TSH, that will tell the cell to break down the colloid. The colloid is broken down. Here we have some thyroglobulin molecule, the large molecule. These vesicles are fused with lysosomes, and that causes an enzymatic reaction which frees T3 and T4. T3 and T4 are lipid soluble. They're going to go into the capillary system. They're going to find binding proteins like thyroglobulin binding protein, and thyroglobulin is then going to carry thyroid hormone around in the blood and take it to its target. The fact that it's being carried by protein carrier is what extends its half-life. So in terms of the regulation of thyroid hormone, when you have low levels of T3 and T4, that causes the stimulus of TRH from the hypothalamus. That TRH goes through the portal system directly to the anterior pituitary. The anterior pituitary produces thyroid stimulating hormone. That goes to the thyroid gland. Here we see the follicle structure within the thyroid gland that tells the thyroid cells to uptake iodide, to make more T3 and T4, and also to break down T3 and T4 and release it into the blood. If T3 and T4 go into the blood, they can feed back to the anterior pituitary and the hypothalamus to make sure that T3 and T4 levels don't get too high. So metabolism is being regulated by negative feedback through this negative feedback regulation process. So you can have too much thyroid hormone, meaning you have too much T3 and T4. That means you're going to have an excessive metabolic rate. You're going to produce a lot of heat, and you'll be hot all the time. You'll have a very high metabolism. You will have a voracious appetite and will be burning calories like crazy. You will upregulate your beta receptors. You'll be highly sensitive to sympathetic output, high heart rate, high contractility, perhaps high blood pressure. However, maybe your diastolic value won't be that high because you've got to vent all that heat. You would have an increased GI function, tend to have diarrhea. There are central nervous system effects. People are very volatile. And an example of a thyroid disease where you have too much thyroid hormone is Graves' disease, which is a kind of autoimmune disease. Hypothyroidism is not enough, and you're more likely to see hypothyroidism in your practice than hyperthyroidism. So there are decreased levels of T3 and T4, therefore this person has a depressed metabolic rate. They don't feel like eating, and yet they gain weight. They feel cold all the time. They're very, very tired and very depressed. Thyroid hormone has an effect on the extracellular matrix such that there's an oversynthesis of glycosaminoglycans that causes a pitting edema called myxedema. The hair falls out, the skin is dry, and that's a terrible symptom. Hashimoto's thyroiditis is an autoimmune disease. That's the most common cause of hypothyroidism. There are antibodies that are destroying the thyroid gland and so that they can't function. All right, I'm going to talk about calcium and bone maintenance and parathyroid hormone. So let's first introduce a bone. Here's a long bone. On the ends, those are that's the epiphysis, and then you see the epiphyseal plate. So in this part of the bone is cancellous bone, so there's red bone marrow in there. There's a long cavity that's often filled with fat, so yellow marrow. And the shaft of the bone tends to have compact bone. And then if we were to look at this end of the bone, the other diaphysis, we would see, the other epiphysis, we would see some more red bone marrow. So there are lots of different kinds of bone cells. There's a stem cell called an osteogenic progenitor cell. Those can differentiate into a cell called an osteoblast. Osteoblasts are bone-forming cells. And as these cells lay down bone, osteoblasts get trapped in the bone and then they turn into osteocytes. And their job, notice these long projections, they're going to send those through the bone so the cells can talk to one another, and that maintains the bone health. There's a completely different cell. It's from a monocyte cell line that differentiates into an osteoclast. These are the cells that break down bone. Bone breakdown is called resorption. So here's some bone. Here's the cancellous bone or the spongy bone. That's There's quite a bit of turnover in that kind of bone. And here you see the compact bone. So there are canals that the vascular system can run through, and then there's sort of concentric circles of bone and bone and bone, and these little eyelash-looking things. Those are the osteocytes. And on the outside of the bone are the osteoprogenitor cells, the osteoblasts, and the osteoclasts. So bone is a very important storage place for calcium. So bone is made of a calcium phosphate salt called hydroxyapatite, and bone is regulated by hormones, but the thing that you are regulating through homeostasis is calcium. So if you're not getting calcium in the diet and performing weight-bearing exercise, then you will continue to pull calcium out of the bone so that you have enough calcium in your blood. So you're not regulating the bone by homeostasis, you're regulating the blood, which is why bone can get compromised with various disorders. Now here is how it's supposed to work. If you have a high level of calcium, that stimulates the release of a hormone called calcitonin. Calcitonin is very active in children. It's active in pregnant women. And calcitonin is a hormone that promotes the deposition of calcium in the bone matrix. So then if you take high calcium and you put it in the bone, then that gets the calcium level back to where it should be. Typically, we're not dealing with high levels of calcium in the blood. Typically, what we're dealing with is low levels of calcium in the blood. And low levels of calcium in the blood is the stimulus for parathyroid hormone. And parathyroid hormone comes from the parathyroid glands at the back of the thyroid gland. Parathyroid hormone is a peptide, and it does a number of things. It's going to promote the release of calcium from the bone matrix into the blood. Essentially, parathyroid hormone works on cells that are very much like the parietal cells in the stomach and the alpha intercalated cells in the kidney. They produce this acid, and the acid breaks down the bone. And then the bone increases in the blood. So you increase your calcium level. Parathyroid hormone is also going to work on some other things. It's going to work on the kidney to take vitamin D and turn it into a hormone called calcitriol. And calcitriol is going to bind to cells in the gut. Calcitriol then increases gene transcription of calcium channels and calcium binding proteins that allow us to reabsorb calcium from the gut. Parathyroid hormone is also going to go to the kidney and work on kidney cells that parathyroid hormone also causes an increase in gene transcription, and you make calcium channels and calcium binding protein. So you get calcium reabsorption, and that's going to happen in the distal tubule. Hopefully then you bring your calcium levels back up to healthy levels. So what if you have too much parathyroid hormone? You are going to have calcium levels that are too high. You're going to increase bone resorption, or pulling calcium out of the bones. And when you have too much calcium in the blood, you'll be filtering that calcium. That calcium exceeds a solubility product, and you form calcium phosphate stones in the kidney system, so kidney stones. I don't know what the mechanism is, but high levels of calcium also will contribute to insulin resistance. What if you have hypoparathyroidism? Well, if you don't have enough parathyroid hormone, then you will not be able to respond to low levels of calcium, and calcium will be low. And what have we learned previously? When calcium levels are low, then voltage-gated sodium channels are more excitable. And that increased excitability is seen everywhere, but a place where it's very dangerous in terms of administering anesthesia is spasms in the larynx. So laryngeal spasms, and then you have a patient where you're unable to get the tube into the trachea, and that's a bad day. So so I want to build on what you already know, that hypocalcemia makes you more excitable, and a place of high excitability that you're worried about is the muscles around the larynx. All right, let's talk about the adrenal gland. So on top of the kidneys are a couple of glands called the adrenal glands. The adrenal medulla produces epinephrine, and the adrenal cortex produces a couple of steroids, cortisol and aldosterone. We release cortisol when we're stressed. So when we're stressed, we release CRH from the hypothalamus, which goes through the portal system. We get ACTH from the anterior pituitary. ACTH goes to the adrenal gland, and we get cortisol. So cortisol is your stress hormone. Essentially what it does is cause the breakdown of tissues in the periphery, sends those substrates to the liver for repair. So you're going to increase blood glucose level. You're going to break down fat in the periphery. You're going to break down protein in the periphery and send that glucose, fat, and amino acids to the liver to mount the repair process. It's also going to increase the transcription. Actually, it's going to decrease transcription of proteins that would result in inflammation. And as a result, cortisol delays inflammation. So when you're stressed out and you're trying to survive an acute stress, you don't need to get all inflamed. Wait till the emergency is over, then you can become inflamed. Very, very important, you cannot live without cortisol. And why is that? Because when you have a stress response, you're going to release a bunch of epinephrine and norepinephrine, and you run the risk of downregulating your alpha receptors. If you downregulate your alpha receptors, your blood vessels are less responsive to catecholamines, and your blood pressure is going to tank. So cortisol's job is to make sure your catecholamine receptors do not downregulate, so your cardiovascular system maintains its integrity throughout the stress event. This is why you have to have cortisol to live. And so the nurse anesthesia students may have examples of where they've had patients who have been on steroids. The excess steroids have inhibited their endogenous production of steroids. You get them in the operating room, and you have a heck of a time maintaining their blood pressure until you give them a glucocorticoid, and then your patient is much better able to maintain blood pressure. What happens if you have too much cortisol? You have something called Cushing's disease. Well, think about what cortisol does. It breaks down fat in the periphery and sends it to the core. So a person with hypercortisolism or Cushing's is going to have skinny little arms and truncal obesity. They are going to have hyperglycemia and insulin resistance. They're going to have peripheral catabolism. So proteins in the periphery are going to be broken down. So muscle wasting. The skin gets thin and actually can kind of stretch out, and you get these stretch marks called purple striae. Because you have excess cortisol and it's doing such a good job of maintaining the sensitivity of the blood vessels, you actually have hypertension. You can have immunosuppression and poor wound healing, and very high levels of glucocorticoids have effects on the brain, and people can actually become psychotic. Now, what if you have elevations not in cortisol, but in aldosterone? That's a condition called Conn disease. Now think about what aldosterone does. Aldosterone increases gene transcription of sodium and potassium channels in the sodium-potassium ATPase. You reabsorb lots of sodium. Later on in the tubule, water follows, so that increases plasma volume. Therefore, these folks will have a high plasma volume and hypertension. In addition, you will excrete lots of potassium, so they will have hypokalemia and alkalosis. So remember, hypokalemia tends to go with alkalosis. Hyperkalemia tends to go with acidosis. So these folks will have excitability changes, dysrhythmias, and the alkalosis tends to make you more excitable. The hypokalemia tends to make you less excitable, and God knows what will happen. Definitely heart dysrhythmias, suppression of the SA node, and ectopic foci. What if you don't have enough cortisol or hypocortisolism? You have something called Addison's disease. So you're going to have decreased cortisol and aldosterone. This is often an immune disorder where the adrenal gland is attacked by antibodies. If you don't have cortisol and aldosterone, you're going to be weak and tired, inability to cope with stress, inability to maintain blood pressure, inability to respond to stress. I don't have it here, but hypoglycemia, decreased blood volume and hypotension. If you're not able to get rid of potassium, you'll have hyperkalemia, which may exchange and cause acidosis. And it's not unusual for people with Addison's to then have other autoimmune disorders. So fatigue syndromes or vitiligo or other kinds of things. A pheochromocytoma is a tumor that produces excess norepinephrine. That could be in the adrenal gland, but it doesn't have to. Tumor could be elsewhere. So these folks are going to produce excess norepinephrine or excess sympathetic output. And maybe they have hypertension all the time, or maybe they just have hypertension when they're stressed. And when could a person be stressed? With the induction of anesthesia. So if a person had a pheochromocytoma that was undiagnosed, it's entirely possible if you had that patient in your OR, try to intubate them and induce anesthesia, that you'd see their blood pressure just go crazy, just increase like crazy. That the process of undergoing anesthesia is causing a tremendous release of norepinephrine and high blood pressure. So let's just have a discussion about stress. Stress is kind of a 20th century, and I guess I should say 21st century concept. People used to be very, very stressed, but they were stressed in a very physical way. They were, they were working in the coal mines. They were trying to grow a crop. They were trying to build a log cabin. I mean, they were really physically stressful. And the world we live in, we're more emotionally and mentally stressed. And it seems to have a different manifestation. When we think about the history of stress, we think about a guy named Hans Selye, who did a lot of experiments on animals and observed their responses to extreme stress, and observed that animals would get stressed. When the stress was over, they could come back to normal. But if the stress went on and on and on, animals could get so stressed that they died. They'd get terrible ulcers and would die. And he called that general adaptation syndrome. And then we had a French physiologist by the name of Claude Bernard talking about the internal milieu, and the idea of physiology was about keeping cells constant. And then Walter Cannon came along and invented the term homeostasis. And so homeostasis is about responding to stress, but homeostasis is so much more in that we're responding to stress in the right direction and the right amount. My blood pressure goes up a little bit, then I lower it a little bit. My temperature goes down a lot, then I do a lot of things to try to get my temperature back up. And our ability to maintain homeostasis is very influenced by the stress that we're feeling. And so there's a whole new field called psychoneuroimmunology. How is mental and emotional stress affecting the brain and affecting the immune system? So ordinarily, when we have a normal acute stress response, we increase CRH from the hypothalamus. That causes an increase in ACTH from the anterior pituitary, and that we get cortisol from the adrenal gland. We make sure we have enough blood glucose to get through the stress. We make sure our blood vessels don't crash during the stress. We postpone inflammation during the stress, and when the stress is over, then we can go back to normal and repair whatever happened. In addition, when we're stressed, we activate a brain nucleus called the locus ceruleus, which then mounts a sympathetic response. And we get the release of norepinephrine, making sure we maintain blood pressure, making sure we maintain blood glucose level. So here we see a diagram of this when we have some kind of stressor. Hypothalamus activates the anterior pituitary, ACTH then goes to the adrenal cortex, and we get steroids. We also can stimulate sympathetic pathways and get catecholamines. So epinephrine and norepinephrine are going to elevate the cardiac output, constrict blood vessels, increase breakdown of lipids, break down our glycogen stores, suppress insulin, increase respiration, enhance blood coagulation. We are ready for that stress. Steroids are going to increase gluconeogenesis, protein catabolism. We're saving glucose for the brain. We don't want to make a bunch of stuff. We're trying to survive. We want to make sure our vascular system remains sensitive, and we're going to suppress the immune response until the stress is over. So, what happens when you're chronically stressed? I mean, the way the system is supposed to work is you get stressed out, you survive, you go crawl off into your cave somewhere, and you calm back down. But what happens if you're stressed, and you're stressed, and you're stressed? There can be all sorts of neuropsychological manifestations, and requiring the help of a psychiatrist. There can be dysrhythmias, there can be hypertension, there can be stroke, there can be coronary artery disease. So if you have really high blood pressure, and that high blood pressure damages your endothelium, and you're coupling that with a bad high-fat diet, and you have terrible atherosclerosis, there's a person that's a stroke waiting to happen, or a heart attack waiting to happen. Now, we've talked about irritable bowel disease and ulcerative colitis, gastritis, that kind of thing. Certainly there is an influence of the sympathetic nervous system on the GI tract. It's not as simple as you get stressed out and then you get an ulcer, or you get stressed out and you have ulcerative colitis. There are other things going on, but certainly stress is a contributing factor. You get stressed out, and that affects the reproductive system. You know, certainly in terms of effects on the menstrual cycle. There are all kinds of theories about why there's such a high level of asthma. You have children that aren't getting enough exercise, children that are stressed out because there are bullets flying in their neighborhood. So what's the role of stress in the manifestation of asthma? You can have prolonged immunosuppression. Certainly hyperglycemia and diabetes is exacerbated by stress. You can have a person with type 2 diabetes, and if they're stressed enough, they will actually go into a diabetic ketoacidosis, something that you would expect to see only with type 1 diabetes. And then we have effects on the muscular system, and all the tension in the muscular system. So stress is an important component, and maybe it's a vital sign. You ask people about their pain level. Maybe we should also ask people about their stress level. So I will end it here, and I look forward to our discussions in class, and we'll also be doing a case study, and we're coming in the home stretch of clinical physiology. And thanks for listening, and I'll see you in class.